Picture this, a man named Gerald. He's 0:0272 years old, retired, sharp as a tack, 0:06. He goes into the hospital on a Tuesday, 0:08, for what his doctor calls a routine 0:10 procedure. Nothing emergency, nothing 012 dramatic. He feels fine going in. The 014 nurses are kind. The paperwork is 017 standard. He signs what they hand him 020 because that's what you do. 4 days 021 later, Gerald goes home. He recovers 024 well. And then about 3 weeks after 027 discharge, the bills start arriving. 1030 is from a surgeon he never met, an out of 032 network specialist who assisted in the 034 procedure without Gerald's knowledge. 036-1 is from the hospital for his entire 039 stay, not covered by Medicare the way he 041 expected, because it turns out Gerald was 044 never formally admitted as an in. He was 047 classified as something called 048 observation status. And because of that 051-1 classification, Medicare won't cover 053, the rehabilitation facility his doctor 055 recommended. Gerald did nothing wrong. 057. He asked reasonable questions. He 100 followed every instruction, but nobody 102 told him the 5 things that could have 104 protected him. And by the time he 106 understood what had happened, the window 108 to appeal had already closed. My name is 111, Dr. William Parker. I've spent 21 years, 114, specializing in senior health, and what 116 I'm going to walk you through today are 118 those 5 things. 5 hospital and 120 Medicare traps that catch seniors every 123 single year. Not because they're 125 careless, but because nobody explains 127, the rules clearly enough before at 129 matters. Stay with me through all 5. 132. Trap number 4 is the one most people 134 never think to ask about. And trap 137 number 5, the one about how hospitals 139 classify you, is the most financially 141 consequential thing I cover on this 143 entire channel. It only makes sense once 145 you understand what comes before it. If 148 this channel is new to you, subscribe 150 now. This is what we do here. Calm, 153 clear guidance for adults who want to 155 understand the system before the system 157 makes decisions for them. Let's get into 159 it. Before I give you the 5 traps, I 202 need to give you one framework first 204 because without it, the individual traps 206 won't fully connect. I call it the 208 assumption gap, and it's the reason 210 Gerald's story happens thousands of 212 times every single day across this 214 country. Here's what changes about your 216 relationship with the healthcare system 218 after 65. 3 things specifically. 221 first, the rules become more complex. 224, not less. Most people assume that once 226 you're on Medicare, coverage is 228 straightforward. In reality, Medicare's 231 rules around hospital admissions, 233 observation status, and post-acute care 235 are among the most complicated in the 238 entire U.S. healthcare system. What you 240 don't know genuinely costs you money. 242. Second, the paperwork you sign carries 245 more weight than you realize. Admission 247 documents at most hospitals contain 249 financial clauses that most patients 252 never read and that most staff never 254 explain. Signing without understanding 257 can legally transfer financial 259 responsibility to you for costs that 301 might otherwise be disputed. Third, and 304, this is the one that connects 305 everything. Hospitals and insurers 307 operate inside a system designed around 310, their interests, not yours. That's not 312 cynicism. That's how the incentives are 315 structured. The assumption gap is the 317 space between what most seniors believe 319 their coverage includes and what at 321 actually includes under specific 323 conditions. Every trap on today's list, 325 lives inside that gap. Keep that 328 framework in mind as we go through each 331. Now, I want to ask you something. 332, think back to the last time you or 335 someone you love dealt with a hospital 337 stay or even an ER visit. Do you 340 remember how fast the paperwork moved? 342, how quickly someone put a clipboard in 344 front of you? How little time there was 346 to read anything carefully, let alone 348 ask questions? Most people I talk to, 351, describe the same experience. You're 353 focused on the health situation. You 356 trust the institution. You sign what 358 they hand you and assume that's the 4 o'clock right thing to do. Nobody pulls you 402 aside and says, here are the 5404 things you need to ask before you agree 405 to anything. If any of that sounds 408 familiar, this video was made 410 specifically for you. Here's what I need 412 you to understand before we go any 413 further. The financial and coverage 416 problems that follow hospital stays for 418 seniors are not inevitable. They are 421 largely preventable if you know the 423 right questions to ask at the right 425 moments. The rules exist. The 426 protections exist. Federal law gives you 429 rights inside that hospital that most 431 people never exercise, simply because 433, they didn't know they had them. That's 435 what today is about. Not fear, not doom. 439 practical knowledge that puts you back 441 in control. Before we go deeper, if you 443 want a written guide that maps out these 445 protections and questions in one place, 447, I've put together a free resource linked 449 in the description below. It's called 451, the longevity guide, and thousands of 453 people in this community are already 455 using it. Grab it now and follow along. 458. Let me explain something about how 459 hospitals and insurers process patients. 502. Because once you see this clearly, the 5035 traps make immediate sense. When 506 you arrive at a hospital, two separate 508 systems activate simultaneously. At the 511 clinical system, doctors, nurses, 513 treatment is focused on your health. The 515 administrative system, billing, coding, 518 classification is focused on how your 520 stay is categorized for payment 522 purposes. These two systems do not 524 always communicate well. And the 526 category your stay gets assigned to, 529 often within the first few hours of 530 arrival, can determine tens of thousands, 533 of dollars in coverage outcomes. Think 535 of it like checking into a hotel. 538. Whether the front desk logs you as a 540 standard guest or conference attendee, 542 changes which services are included in 544 your rate. You're staying in the same 546 room, you're getting the same breakfast, 548, but the billing is completely different, 551, and nobody at the front desk is required 553 to explain the difference unless you 555 ask. That's the system you're navigating 557 every time you or someone you care about 559 enters a hospital. A report from the 602 Office of the Inspector General found 604 that Medicare patients who were placed 606 under observation status rather than 609 formally admitted faced an average of $611, $700, $613 more in out-of-pocket costs per hospital 616 stay compared to those formally admitted 618 as inpatients. That's not a billing 621 error. That's the system working exactly 623 as designed. Now here's what I found in 626, 21 years working in this space. Their 628 are 5 specific traps inside that 631 system that seniors encounter most, 633 frequently and most preventably. I've 635 ordered them from common to most 637 critical, so you know where to focus your 639 attention first. The last one affects 642 more people than any other item on this 644 list, and the financial consequences can 647 be devastating. But you need to 649 understand the first 4 to fully 651 appreciate why. Let's start. Trap 1, 654 out of network surprise bills. When 656 Barbara was 68, she had solid Medicare 659 coverage and a supplemental plan she'd 702 carried for years. She went in for a 704 planned cardiac procedure at an INET 706 network hospital, asked the right 708 questions about her surgeon, confirmed 710 he was in network. 3 weeks later, she 713 received a bill for over $4,000 from a 716 anesthesiologist she had never met, and 718 never chose, someone who assisted in the 720 procedure and was not in her network. 723. Most people assume that if the hospital 725 and the primary physician are in 726 network, everyone involved in their care 729 will be. That assumption is wrong. 731 hospitals routinely use contracted 734 specialists, anesthesiologists, 736 radiologists, pathologists, surgical, 738 assistants who maintain their own 740 separate network agreements. These 742 providers can bill independently, and in 745 network status for the hospital does not 747 extend to them automatically. The No 749 Surprises Act, which took effect in 752 January 2022, provides federal 755 protection against many of these bills. 757 under this law, for most planned 759 procedures, out-of-network providers 801 cannot bill you more than your INET 803 network cost-sharing rate without your 805 explicit written consent in advance. The 808 keyword is explicit. If you sign a 810 general financial consent form without 812, realizing it contains a clause waiving 814 your No Surprises Act protections, that 817 waiver can hold. The practical guidance 819 is this. Before any planned procedure, 823 ask the hospital in writing for a list 825 of every provider who will participate 827 in your care. Ask specifically which of 830 those providers are in your network. If 832 any are out of network, ask whether you 834 can request an in-network alternative. 837. And if you're asked to sign any document 840 consenting to out-of-network billing, 842 read that clause carefully before you 844 sign it. The common mistake is assuming 847 that a signed general consent form 849 doesn't carry specific financial 851 implications. It often does. Any form 854 that includes the phrase financial 856 responsibility or non-participating 859 provider deserves a careful read before 901 your signature goes on it. If you 903 receive a surprise bill after a 905 procedure and believe the no surprises 907. Act applies to your situation, you have 910, the right to dispute it. The federal No 912 Surprises Act dispute process is 915 available through CMS, the Centers for 917 Medicare and Medicaid Services, and your 919 insurer is required to provide 921 information about how to initiate it. 923. Within the first 30 days after receiving 926 a bill you believe is incorrect, contact 928 your insurer and request an itemized 930 statement. Document every call. The 934 earlier you raise the dispute, the more 936 options you have. Now trap 2 is one 939 that catches people in a completely 941 different moment. Not when the bill 942 arrives, but when the hospital tells you 945 it's time to go home. Trap 2, 947 premature hospital discharge. Harold was 957.40. He'd been admitted after a fall that 952 resulted in a hairline fracture. After 39.55 days, a hospital administrator, not his 957 physician, informed him that his 959 insurance had approved his stay through 10:01 the following morning and that he should 10:03 plan to be discharged. Harold felt 10:05 unsteady. His pain wasn't well 10:07 controlled, but he assumed that if the 10:09 insurance said it was time to go, it 10:11 must be medically appropriate. He was 10:13 discharged. He fell again at home 10:15 days later. Here's what Harold didn't 10:17 know. Medicare beneficiaries have the 10:20 legal right to appeal a hospital 10:22 discharge decision before leaving the 10:24 same day if necessary. This is not a 10:27 complaint process. It is a formal 10:29 federal right. It is called a Quality 1031 Improvement Organization Appeal or QIO 1034 appeal. Every Medicare patient must be 1036 given a written notice called the 1038 Important Message from Medicare, which 1040 explains this right before discharge. If 1042 you were not given this notice, the 1044 hospital is out of compliance. A study 1046 from the Commonwealth Fund found that 1048, approximately 1 in 5 Medicare 1050 patients is readmitted to the hospital. 1052 within 30 days of discharge, and 1054 premature discharge is one of the most 1056 frequently cited contributing factors. 1059 remission carries its own set of costs, 1101 risks, and coverage complications. The 1104 practical guidance is this. If you or a 1106 family member feels that discharge is 1109 happening before it is medically safe, 1111 request a QIO appeal immediately. You do 1114 not need a lawyer. You do not need your 1117 doctor to agree with you. You call the 1119q.io. The phone number must be on the 1121 important message from Medicare document 1123 and request a review. Medicare will pay 1126 for your continued stay while the appeal 1128 is reviewed. The hospital cannot 1130 discharge you during that review period. 1132. The common mistake is waiting until 1134. You're already home to raise the 1136 concern. Once you leave, the appeal 1138 process changes significantly and your 1141 options narrow. The time to act is 1143 before discharge, not after. Quick pause 1146 here. Have you or someone in your family 1148 ever felt that a hospital discharge 1150 happened too fast? Drop a yes or no in 1152. The comments. In my experience, this is 1155, far more common than people realize. And 1157, the people who successfully appeal are 12 o'clock, almost always the ones who knew this. 1201 right existed before they needed it. 1204, trap 3, medication substitutions, 1207 during your hospital stay. Ruth was 71. 1210. She took 4 medications daily. One's 12-12 her doctor had carefully selected, and 12-14 adjusted over several years. When she 12-17 was admitted for a knee replacement, the 12-19 hospital substituted 2 of those 12-21 medications with alternatives from their 12-23 own formulary, which is the hospital's 12-25 approved list of drugs. Nobody asked 12-28 her. Nobody explained why. She assumed 12-30, the hospital knew best. After discharge 12-33, she experienced side effects she hadn't 12-35 had before and spent 2 months working 12-37 with her doctor to restabilize her 12-39 regimen. Here's what most people don't 12-41 know. Hospitals maintain their own 12-43 formularies, approved drug lists, and 12-46 when your regular medication isn't on 12-48 that list. They will often substitute in 12-51 alternative without specific patient 12-53 consent beyond the general admission 12-55 paperwork. This is standard practice. At 12-57 is also legal, but it creates real 1300 problems when the substitute behaves 1302 differently in your body, interacts with 1304 other medications you take, or creates a 1307 transition challenge at discharge when 1309 you return to your original regimen. A 1311 report published in the American Journal 1313 of Health System Pharmacy found that 1315 medication discrepancies at hospital 1317 admission affected a significant portion 1320 of older adults, particularly those on 1322-5 or more medications, and that these 1324 discrepancies were a leading cause of 1326 adverse drug events during and after 1328 hospitalization. The practical guidance 1331 is this: before any planned hospital 1334 stay, write out a complete medication 1336 list. Every drug, every dose, every 1339 frequency, including over-the-counter 1341 medications and supplements. Bring that 1344 list with you when you're admitted. Give 1346 it to your care team and ask 1348 specifically, will any of these 1350 medications be substituted during my 1352 stay? And if so, can you explain the 1354 rationale and how we'll transition back 1356 at discharge? You have the right to 1358 ask. You have the right to involve your 1400 own physician in that conversation. The 1403 common mistake is assuming the 1404 hospital's pharmacy team is 1406, automatically coordinating with your 1408 regular doctor. In many cases, they are 1410 not. The handoff is your responsibility 1413 to initiate. This is not medical advice. 1416. Your specific medications and medical 1418 history require a conversation with your 1420 own physician. But the habit of bringing 1422, a complete written medication list, to 1424 every hospital encounter is one of the 1427 most protective things you can do. Now 1429, we're going to shift gears. What I'm 1431 about to cover next is the part of the 1433 hospital experience that most people 1434 never think about until it's already 1437 happened to them. These last two traps, 1439, are where the real financial exposure 1441 lives. Trap 4, financial 1444 responsibility forms buried in admission 1446 paperwork. Most people know they'll be 1448 asked to sign paperwork when they're 1450 admitted to a hospital. What most people 1452 don't know is that those documents, often 1454, contain financial clauses that go 1457 significantly beyond standard consent to 1459 treatment. Martin was 69. He was 1502 admitted through the emergency 1504 department after a cardiac event. 1506. Understandably, he was not in a position 1508 to read carefully. He signed everything 1511 quickly. Among the documents was a 1513 clause agreeing to be financially 1515 responsible for any charges not covered, 1517 by his insurance, including charges that 1520 arose from coverage disputes. 18 months, 1523 later, when his insurer denied a portion 1525 of his claim, the hospital used that 1527 signed document to pursue him directly, 1530 for the balance. A 2021 analysis by the 1533 Kaiser Family Foundation found that more 1535 than half of American adults reported 1537 difficulty affording healthcare costs 1539, and that surprise billing and unexpected 1542 out-of-pocket charges were among the most 1544 commonly cited sources of financial 1546 hardship. For seniors on fixed incomes, 1549, a single unexpected hospital bill, can 1552 represent months of income. Here's what 1555 you can do. If you have any capacity to 1558 review admission paperwork, or if a 1600 family member or advocate is with you, 1603 looks specifically for language about 1605 financial responsibility, assignment of 1608 benefits, and non-covered charges. You 1611 are allowed to ask questions before you 1613 sign. You are allowed to cross out, or 1615 annotate specific clauses. Write, I do 1619, not agree to this clause next to any 1621 language you're uncomfortable with, and 1623 initial it. This does not guarantee the 1626 hospital will honor your annotation, but 1628, it creates a documented record of your 1631 objection that can be relevant in a 1633 billing dispute. If you are admitted 1635 through an emergency and cannot review 1637 documents in advance, you can request a 1639 copy of everything you signed once you 1642 are stable and you have the right to 1644 dispute charges that arose from clauses 1647 you are not in a position to review. 1649. The common mistake is assuming that 1651, because you signed something quickly 1652 under duress, you have no recourse. That 1655 assumption is not always correct. Many 1657 billing disputes are successfully 1659 resolved after the fact, but they 1701 require documentation and persistence. 1703. Now, here it is, the trap that changes 1706 the conversation entirely, and it is the 17081 one that connects directly back to 1710 Gerald's story at the beginning of this 1712 video. Trap 5, observation status 1714 versus inpatient admission. This is the 1717 most misunderstood and most financially 1719 consequential classification in 1721 Medicare. And I want to explain it 1723 clearly because the details here matter 1725 enormously. When you arrive at a 1728 hospital and a physician orders you to 1729 stay, you and your family will almost 1732 certainly assume you have been admitted 1734 as an inpatient. In a significant number 1736 of cases, you have not. You may have 1738 been placed under observation status, a 1741 classification that means under 1743 Medicare's rules. You are technically in 1745 outpatient receiving extended monitoring 1748, even if you are occupying a hospital bed 1750 for multiple days. The practical 1753 difference is staggering. Under Medicare 1755 Part A, inpatient admissions cover your 1758 hospital stay and critically make you 1800 eligible for post-acute rehabilitation, 1802 coverage at a skilled nursing facility, 1804, provided you meet the 3-day inpatient, 1807 stay requirement. Under observation 1809 status, none of that applies. Your 1811 hospital stay may be billed under 1813 Medicare Part B instead of Part A, often 1816 at higher out-of-pocket cost, and you are 1818 not eligible for covered skilled nursing 1820 facility care regardless of how many 1822 days you spent in the hospital. A report 1825 from the U.S. Government Accountability 1827 office found that the number of Medicare 1829 beneficiaries placed under observation 1831 status for more than 48 hours increased 1833 by over 96% between 2006 and 2014. And 1838, that many of these patients were unaware 1840 of their classification until they 1842 received the bill. The financial 1844 consequences for those who needed 1846 post-acute rehabilitation care were 1848 severe, with some patients facing 1850 skilled nursing facility costs of $50,000, 1852 or more per day that Medicare would not 1855 cover. The Notice of Observation, 1857 Treatment and Implication for Care, 1859 Eligibility Act known as the Notice 1901 Act requires hospitals to notify 1903 Medicare beneficiaries in writing within 1905 36 hours if they are under observation 1908 status rather than admitted as 1910 inpatients. That notification is called 1912, the Medicare Outpatient Observation 1915. Notice or MON. You are entitled to 1917, receive it. If you don't receive it, 1920, ask. The practical guidance is this. 1922. Within the first 24 hours of any 1924 hospital stay, ask your nurse or care 1927 coordinator directly, am I formally 1929 admitted as an inpatient or am I under 1931 observation status? Write down the 1934 answer and who gave it to you. If you 1936 are under observation status and you 1938 believe your condition warrants 1939 inpatient admission, you or your 1941 physician can request a status review. 1944. Your doctor's clinical judgment about 1946. The appropriate level of care carries 1948 significant weight in that review. And 1950, here's what to do. Instead of waiting to 1951, find out at discharge, ask on arrival. 1954. Ask again after 24 hours if the answer 1957 was observation status. If you're told 2000 inpatient admission requires 2001 authorization, ask who is responsible 2004 for pursuing that authorization and what 2006 the timeline is. The common mistake, and 2009 it is the most costly mistake on this 2011 entire list, is assuming that if the 2013 hospital put you in a bed and kept you 2015 for 3 days, Medicare will count 2017, those 3 days towards skilled nursing 2019 facility eligibility. That assumption 2022 has cost seniors and their families 2024 hundreds of thousands of dollars in 2025 uncovered rehabilitation costs. The 2028 question cost you nothing to ask. The 2030 answer can change everything. Before I 2032 give you your 30-day action step, I want 2034 to leave you with something you can use 2036 at your very next hospital encounter, or 2039 give to a family member who might face 2041-1. I call it the hospital admission 2043 safety protocol. 5 questions. Write 2045 them down. Put them in your phone. Give 2047 this list to whoever is most likely to 2049 be with you in a hospital setting. 2051. Question 1. Am I being formally 2053, admitted as an inpatient, or am I under 2056 observation status? Question 2. Can 2058 you give me a list of every provider who 2100 will be involved in my care today, and 2103, which of those providers are in my 2104 insurance network? Question 3. Will 2107 any of my current medications be changed 2109 or substituted during this stay? And can 2112 my own physician be consulted before any 2114 changes are made? Question 4. What 2117 are my rights if I believe I am being 2118 discharged before I am medically ready 2120 to leave? Question 5. Is there 2123 anything in the paperwork I'm being 2124 asked to sign that makes me financially 2126 responsible for charges my insurance may, 2128 not cover? Any good hospital patient 2130 advocate, social worker, or physician 2132 will welcome these questions. And if the 2134 response you receive makes you feel that 2136 asking was somehow inappropriate, that 2139 tells you something important too. Here, 2141 is your 30-day action step. And I want 2144 to make this specific because vague 2146 intentions don't translate into 2148 protection. This week, not in 30 days, 2150 this week. Create what I call a hospital 2153 readiness file. It takes about 2156 minutes. Write down every medication you 2158 take, the dose, and how often you take 2200 it. Add your primary care physician's 2203 name and direct phone number. Add the 2205 name and phone number of one family, 2206 member or trusted friend who can 2208 advocate for you if you're not in a 2210 position to advocate for yourself. Write 2213 down your insurance information, 2214 including your Medicare number and any 2217 supplemental policy details, and write 2219 down these 5 questions from today. 2221. Put that document somewhere you can grab 2223. It quickly and tell the person you. 2225 listed as your advocate where it is. 2228. That file is your protection. Not 2230 because anything bad is going to happen, 2232, but because the people who navigate 2234 hospital encounters most successfully, 2236, are almost always the people who were 2237 prepared before they needed to be. Check 2240 your file in 30 days. Update anything 2242 that has changed. I want to close with 2245, something that I think about often in 2247 this work. There is a difference between 2249, a healthcare system designed to treat 2252 illness, and a healthcare system 2253 designed to protect the person. After 2256-65, navigating those two things requires 2259 more knowledge than most people are ever 2301 given. The traps we talked about today, 2304, are not the result of malice. They are 2307, the result of a complex system that was 2310 never designed with the patients, 2311 financial protection as its primary 2313 concern. The best patient advocates I-2316 have ever encountered, and I have worked 2318 alongside many, are almost never the ones 2321 who are most aggressive or most 2323 difficult. They are the ones who are 2325 most prepared. They ask calm, specific 2328 questions. They write things down. down. They 2331 know their rights before they need them. 2333. That is what you now have. You know what 2335 observation status is? You know what the 2337 No Surprises Act protects you from? You 2340. Know you have the right to appeal a 2341 discharge. You know to read the 2343 paperwork before you sign it. And you 2346 know to bring your medication list every 2348 single time. In 21 years I have watched 2351, that kind of preparation, make a real 2353 measurable difference for the people I 2355 serve. You are not a passive participant 2358 in your own health care. You are a 2400 participant with rights, and today you 2402 know what they are. If this gave you 2404 something useful, subscribe. That is 2406, what this channel is built for. Calm. 2409. Real practical guidance for adults who 2411 want to understand the system before the 2414 system makes decisions for them.